My name's Martin Hall. I've been working at the North Richmond Community Health Centre for 16 years. Prior to that, I worked in various community centres around Australia and overseas. Along the way, I did a Masters in Public Health a few years back at Monash, and I work overseas in East Timor doing a project up there. When I did my Masters, it was in international health, and that's sort of one of my passions, to work overseas as well. But my whole history's been in public health, so unfortunately for you, my whole history hasn't been in academia or presentation work, but we'll see how we go. North Richmond, when I first started, was a two-chair clinic. We moved it to a three-chair clinic. It was those of you who went there would have seen it as a horrible little clinic, but we sort of loved it. In 2011, we got this fabulous new clinic, 7 chairs, and we really love that. It's a fantastic environment to work in. When we moved into the new building, we took all of our hardcore staff, so we had staff that came with us, and then we had to expand. We had to get new staff, and that was one of the enablers of changing to a new model, being able to select staff that are committed to a model of change. At the moment, we have 9 dentists, 4 oral health and dental therapists, 2 prosthetists, 11 DAs, 5 receptionists, and me, the leader. Those of you who are program managers may know that that's more or less a title than a reality sometimes. But this model does come down to leadership as well, because if it's not driven, my experience is a lot of things sort of start off and fade away. So you have to have a level of commitment and leadership. Move on. Sorry, that was that one. Now, I'll present this model under these headings, the elements, and I'll point out some of the things which are different from normal practice. I'm going to talk, well actually I'm not going to talk, I've asked Vang to come along today to talk about the oral health educator role, and then there's implications and sort of what next. In a way, this is our coming out. We've been working on this for 2 years, and I will admit that it's a work in progress and that you'll probably be able to pick faults with it, but there are some people who are quite excited about it, think it's an important change, and I hope you like it. We all sort of know that running a dental program is complicated, and it's sort of hard to keep your head above water sometimes, challenging from day to day. And I guess I can tell the story of how we managed to break away, become innovative, and what were the enablers for that. In a way, our model is not unique, I don't think. It's based on the evidence and rhetoric found in the philosophy of minimal intervention. And the more I read about minimal intervention, I found that that's exactly what we're doing. The narrow definition or the concept of minimal intervention in a lot of practitioners' mind is doing smaller fillings. And it's sort of unfortunate in a way, because it is bigger. And I like the definition that Hien No uses. I might read that. Well, it's paraphrasing, I suppose, but he describes minimal intervention as empowering our clients and their families to achieve and maintain their oral health, so there's minimal input by the dental profession. So it's about changing people's behaviour, adapting healthy lifestyles. Now, and of course, any change has to be for the benefit of our clients. This is some of the feedback that we got from our oral health educator, and I think it's quite telling about what we've been doing in the past and about clients' We know there's far too much disease out there than we can ever handle. We've had some presentations this morning that describe the amount of disease out there, how we only see a small percentage of the population that was eligible. And for those of us who have been around for a while, we don't see things getting any better. We're still doing some of the same things, or almost exactly the same things we were doing 25 years ago. So waiting lists are pretty much the same. We've still got 40% emergencies. And if you believe what the NRCH has said recently, that children's health is getting worse. So maybe there's a smarter way of doing what we have been, than what we have been doing in the past. Now, change is difficult for a lot of people. We have the old core, or the old hardcore I call them. We have a dentist that's been around for 40 years, and myself. And you'd think that people would be sort of set in their ways and say, oh no, I've been doing it this way, I'll do it the same. But there's people who've been working in public health actually choose to be in public health because of wanting to make a change. So the person who I thought would be the most resistant to change said, look, I'm all for it. I've only got 5, 10 more years in my career. I'd love to see a change. And it's the same for me. So and the opportunity came along, I think, and we were opportunistically grabbed it. But I believe that in a lot of our hearts, heads, that we've been looking for change for a very long time. So some of the enablers is a supportive management. My CEO gave me a job description when I first started 16 years ago, and it was be good to the clients, so the client-focused quality of care sort of aspect. The second one was don't embarrass him in the board with the budget. So there was the management and performance issues, productivity issues. And the third one that I really like was come up with some ideas, be innovative. If they don't work, so what? But keep stimulating yourself and the program to come up with some ideas. That's still my job description. It was never actually written down. I probably shouldn't tell you that, but I believe there was a desire for change in the core staff. We had a situation where we could select new staff and we could select people who were committed or showed commitment in that area. We had some very strong DA skills, and we'd been developing them for years, and Vang was there, and she'd already done her level 4 in radiology, and we encouraged her to do the level 4 in oral health promotion. So that was an enabler. And would you believe that the case mix funding model, the DOVE model, was also an enabler because of the less emphasis on item codes and that sort of output productivity. It enabled us to say, well, let's treat the patient as an episode or a course of care, and we can do sort of what we like in there. I'm not sure how that is going now. So look, some of this, Deb Cole stole some of my thunder here because no, she didn't mention this one. 30 years ago, there was a guy called David Barnes, came from WHO and did a review of the South Australian Dental Service, and his recommendation was a model of care in which the dentist was the leader and there'd be a dental therapist doing the preventive and simpler restorative care, and the dentist would receive those referrals and manage the program. And I still think we're looking into that. We haven't quite got there. 25 years ago, and Deb reminded me that it was Owen Makinson, but also Graham Mount, I think, was the first person who coined the phrase minimal dentistry. And he was also a tutor of ours at the Adelaide Dental School. And he knew then that you can't treat away dental caries. But Hanny's not here, but we're still looking into it 25 years later. And as Deb said, it hasn't been taken up, and I wonder why that is sometimes. Retention rates of the best and brightest young dentists. They come into the public service, stay for a couple of years, and then go where the real action is. Same with dental assistants. RMI trains hundreds of dental assistants, but where do they end up? That sort of disappear. So are we creating an environment which is nurturing good staff and creating that environment, a rewarding job satisfaction and rewarding career? And it's very similar to what I think Mike stole my thunder on the other one, where I believe we should be we should develop a model of care which is different from private practice, instead of trying to copy it or you know what I mean. It's just not. We can never compete with private practice in that area. We need to have a focus in public health and create our own style and be proud of it. And as he said, the quality of care is the same. So we shouldn't feel that there's any inferiority to private practice. Lastly, the clients, what do they think of us? And do they still hate coming to see us? And well, you know, how often have we heard, look, no offence, doc, but you know, I hate you. Or I'd rather give birth than have a dental visit. You know, we know it's uncomfortable. So should we be looking for a model that reduces the amount of discomfort in dental care? And I guess what Deb said, should we be valuing client outcomes rather than dentist outputs, to summarise that. The dollars are important in light of the National Partnership Agreement, but we have to avoid perverse incentives that steer us down the treatment track. That's a big challenge for us and the organisation to steer us that way. As you know, it all takes effort, skill and resources to treat those at high needs. And I was right, I'm going to quote Russ from Dudagalla when he said, we must be doing something right because we're going broke. And it's true. Are you still going broke, Russ? Good on you. Because we all know it takes more resources, more time and everything to treat those high needs groups. So we should be sort of smarter about how we do it, otherwise we will go broke, I suppose. So if we can find the real issues, we probably ought to find some of the real answers. Oh, hang on. So look, that's just diagrammatic. I think I've covered it all there. Where am I now? Okay. So what were the elements? I'll probably move through this quickly because I think it was covered by Mike and Shalita, I think. Yeah. But look, we know we don't have enough resources to treat everybody, so we have to put our resources where we're going to do the most good. It has to be preventive, and I use the swimming one where you know, you spend time fixing the bridge so that people don't fall in the river and don't spend all your time dragging them out downstream. And we know that to deal with upstream, it has to be a combination of public and individualised care to solve those upstream problems. And by population approach, I mean to look for the gaps and who's falling through those gaps. So we have to target the ones that aren't receiving care to increase that or decrease the inequity across the community. And by individualised care, I mean client-focused and addressing the needs of the clients, their real needs, rather than just some demands or perceived needs. And working together to increase health literacy and to change behaviour. And this can be done, and we'll talk about how we do that in our model. So a successful model also needs to evolve systems and policies. Staff should work in a coordinated and teamwork, and requires continuous training and innovation. And of course, minimal intervention in the dental. So leadership and organisational support. But what I found was that when you started off as a minimal intervention, and I thought that's what we'll do. And then I found out that you actually have to change everything. And that's the challenge of any model of care that's different. You can't change parts of it without changing just about everything, otherwise the sustainability just goes. So, and it takes a long time. Jolene was telling me she worked overseas and she changed the GP model with blood pressure people, and it took her 2 years. And that's my experience as well. 2 years after sort of conceptualising this, we sort of got to the point where we can sort of start it really, to really go for it. So it takes time and a lot of effort and persistence. So, what does the model look like? This is the blueprint of our model. And as we know, dental disease is complex, and this looks complex, but I'll break it down so that as we move through it, it'll become quite simple. There's 4 parts to it. Hang on. We have the access and approach. We have the assessment. When we have treatment phase, and then down the end we have what I call the 3 R's, which are review, recall and referral. And you'll notice a few, starting at the front, you'll find some new things here called the dental home, welcome area, we all know about letters, and perhaps the drop-in clinic, and something didn't come, anyway, this is where the oral health educator fits in there. I think the title fell off there. Okay, so we'll start with the first one, which is approach and access. Approach and access for us has a double meaning. One is it's about the front end reception area where people get processed and letters get home and all of that. But the other meaning for it is for our staff to be approachable and accessible. So we've worked on both of those aspects. Look, changing a work culture is part of what we've done in this process over the last 2 years. And what our aim is to become more accessible to our clients and responsive. Some of these things will come up as we go through. So the concept of the dental home is something I came across in my reading, and it really fitted in with what we were doing. It didn't have I was sort of developing a dental home without really knowing what I was doing. And the definition of that is an ongoing relationship between dentist and the client, inclusive of all aspects of oral health care delivered in a comprehensive, continuously accessible, coordinated and family-centred way. But more simply, it's a place where clients can feel safe, at home, cared for and respected, and receive as much of their care at one place. So first off, people need to feel welcomed. We've got this welcome area. Now, that used to be called our waiting room. So, and a lot of what we've done is change the words. Changing the words changes the meanings. So it's much better for someone to come in and be welcome than sit down and wait. That's a change you could make tomorrow in your clinics. And it's pretty much an attitude change. We don't have a sign up saying welcome area, but we're slowly using that word more and more. But it's an attitude. But it's not just the front desk's responsibility, it's everybody's. I went to a customer-focused talk a while back, and they used Walmart as an example. And anybody that came with, I think it's the 10-foot rule, anybody that came within 10 feet of you, you look them in the eye and say hello. And that doesn't take much effort, but it really does make the place far more welcoming than, oh yeah, what's your healthcare card number? Go and sit down. It's a difference. And now the reason that we want to create a home is that we want to be able to, we want to connect with our clients so that we can actually steer them towards healthy behaviours. So we have a flat screen and we have quite a nice waiting area. So our receptionists are empowered to reduce barriers rather than create them. Now, I know and that depends on the management style and the direction given, but some of the receptionists have been very good at putting clients off, and we just don't do that. We want clients to be, to like us, basically. They are also empowered to apply the priority policy in a generous way. We have a fast tracking system. That's that. Now, fast tracking, it means if someone comes in and they've got a hole in the front tooth, you know they're going to be high risk. Would you like an appointment? Or if they come in as an emergency, we say, look, you've got a mouthful of disease, we'll bring you back and start working on it. Don't put them on a waiting list if you think they're going to be high risk. Because as Deb said this morning, they're just going to end up worse. And so what's the benefit of that if it's about health outcomes? So we are helpful. We have sort of a yes policy, and the best thing, I'm trying to come up with a good example of that, but we used to have trouble at Fitzroy Clinic where people with drug and alcohol problems would come in and demand something. And I want it now. And you say, okay, yes, sit down, wait. If you're in pain, we'll see you right now. And that would sort of disarm them. They'd say, oh, okay, fine. And it solved a lot of problems. Or, look, if you're not in pain, we've got a very short waiting list, we'll call you within a month and then you can come in. They say, oh, okay. Or if you can't manage to come in then or that, you can come in any Monday morning and just drop in. And so we're giving them alternatives, options, and it dissipated all that aggro that you get from demanding clients. So that's another thing you could probably apply straight away. And courtesy calls. If someone has an oral surgery procedure or a difficult extraction, we ring them up. If it's in the morning, you ring them up in the afternoon. If it's in the afternoon, you ring them up the next day. And that really is a powerful tool for getting your clients on side. We take our language services seriously. So if we're going to, we want our client in the centre of our attention. So it's client-centred approach. So behaviour doesn't happen in a vacuum, and we're trying to create an environment where the client feels engaged, listened to, and we try and find a bit more out about their lives and factors contributing to their disease. Again, we take cultural competency seriously. We have employment policies where we employ people from the community. We have training in cultural competency, and we have translated and intensive use of interpreters. Now, this is where we get to the dental assistant side of things, which Julie talked about. I'll just point out, we all know about the power imbalance. It was talked about yesterday in our workshop, whereby if a client, and most of our clients are in low health literacy, low education, so they see a dentist and they sort of go, oh, you know, this person's important, we'll let them make the decisions for us. We don't want to hear people say, you know, they'll have actually said, all right, what do you want today? And they say, oh, whatever you reckon, doc. And that's very disempowering for the client. So we get the dental assistants. The dental assistants will be allocated to a client, and we try and get someone from the same cultural group or someone who's familiar with that cultural group, so that they maybe have a language connection or at least a sympathetic and understanding there. And we find that the clients at first were a bit confused about that, saying, well, where's the dentist? But we've got here we are, a pre-clinical interview, which it's the next slide, I think. So the letters home, now that's an important change. We send letters home. Now, I don't know if any of you remember the report that came out from Dianella 2009 called Was I on the Waiting List? I suggest you all read that. It's full of really good information and recommendations and how to engage with the clients while they're on the waiting list. What we do is we send a letter home. Everybody that comes on the waiting list gets a nice, colourful letter. Unfortunately, we think that our letters are going in with the little white, with the clear window, and we think it's a bill. So we have to get a stamp or a sticker or something that says, don't throw this as away about your dental health or something on it, because we suspect that there's a problem there. But the letter says, you know, welcome to the waiting list, which is, you know, anyway, and apart from other information, it says, And accompanying it is a letter or a document with simple oral health instructions in language, if we try and match the languages. And in there we say, look, if you've got pain, come in. If you're under 18, come in. Also, if you're not, the wording is, if we expect you to be cleaning your mouth, teeth, and that's teeth, gums and tongue, well, otherwise some dental treatment will be delayed. Now, we'll get on to this aspect of it, but we prepare them at that point and say, look, if you're not brushing well, we're going to put the brakes on some of the treatment, which is what we should all be doing, but in practice it doesn't always happen. We send them another letter, and we also invite them to come in if they want more information about oral health. Come in, and we'll arrange a lesson for you. Not many people have taken up on that, I think a couple, so it hasn't been very successful. We send another letter out with an appointment, a time on it, a day, time, and also reminding them if you're not brushing your teeth well, some treatment will be delayed. So that's the second time they hear that. Now when they come in, the dental assistant takes them, I hope that's come up right, takes them into a non-clinical room. So we've got a little consulting room, which is a luxury of the new building. We were able to plan that in. So the dental assistant goes in there, and it might be in their same language. They go through this set of questions. Now this came from when we did a pilot, and we found it sort of so useful for three reasons. One was that it started the conversation off with the dental assistant with the client, so it started that. Secondly, it provided us with a whole lot of information which was useful for the caries risk assessment and some of their social and attendance. Then the third one, which was very pleasing, was the dental assistants were empowered. So they had a role to play in the client experience. Where are we? Up here, there's a sneaky little question there called first we ask them, did you receive your letters? And then, obviously, if they don't, they're not. If they come as a priority group, they don't get the letter because they're not on the waiting list. But for those that got the letter, we asked, well, what could make this information more useful to you and your family? Now, you could ask, it's a health literacy question, you could ask, do you have problem understanding forms and questionnaires? But we thought that most people would say, oh yeah, no worries, because it's a sort of it's a loaded question. People aren't going to admit to being low literate. So we're forcing them to say something in that point. Now, this whole process takes a bit of training and a bit of skills development in the dental assistant, and it's quite stilted to start with, but after a while it just becomes a conversation and with the information. We do sort of, down here, we've got a line, the dental operator helps down here, but we do make sure the medical history is completed. We ask about snacking and brushing and whether they've got any children. Yeah. When the client attends for their their examination visit.
So in the non-clinical area, the dental assistant takes the patient.
Yeah, and probably the question you think is, well, who's doing the changeover in the clinic? We have to build in a backup, and that's usually the steri nurse.
So this happens in the same day of the examination, just before the exam?
Yes, this is the introduction to their examination. So they come from the welcome area into this room.
And how long is
2-3 minutes. Yeah. I mean, as you get quicker, some people take longer, of course, and some is very quick. Maybe Vang can talk to that a bit later on. But we have been collecting some evaluation from this, and one of the other things which is in there somewhere. Do you think your mouth's healthy? Where is it? Well, what do you expect from your dental visit? Now we can classify that into this. We collect that information. We've been doing some data stuff that we haven't really analysed it fully yet, but we're trying to match whether people, like how many 011s or how many diagnostic, how you group the service mixes or the diagnostic treatment, extractions and all the rest of it, where we think that we can probably match people's expectations and see what they're getting on a an average basis. Have to talk to the evaluation people about that. But then we should be able to see that change over time. If we see more people saying, "Oh, I'm coming here to have an extraction," and more people saying, "Oh, I've come into prevention," then I think we can sort of view that as a success or otherwise, if you get what I mean. So we can longitudinally assess individuals, but probably also we can group it into an average. So that's something different, anyway. And that it's not time consuming, but it's a lot of useful information. And again, the DA's involvement is really important. So then we move on to the assessment phase. And do you want a definition of health literacy? No, good. Past that. Okay, phase 2, assessment phase. Now, look, this is not much different from what we do. We do, well, except for preclinical interview sort of crosses over there. But we do an oral and radiographic examination. And everyone should be doing the CPI as a matter of course. And then the caries risk assessment, we usually do it in our heads, but we've got a tool for that. You may notice we've dropped moderate risk. A lot of the tools use low, moderate and high, and we've changed that from low, high and extreme. And we can talk about that in a minute. So these are our risk categories. I'm not going to talk about extreme risk today, but it's too hard. So we'll talk about high and low, and our aim is to move people from high to low. I think extreme caries is a sort of a different area. It's very individualised, and it's not population-based so much. But it's important. The perio, we choose to, this is just arbitrary, but we thought that a CPI of greater than or equal to 3 2/6 would indicate a high-risk perio. And certain things happen at that point. Any questions on that? No, good. Here's our caries risk assessment. This is where Ben gets a cheer for this, because he's actually taken this form and put it into titanium as an item code, so that we can pull this up on as an item code, and it doesn't look like this anymore. But you can tick boxes, and so we all know that existing caries is the best indicator of future caries. But we've snuck in low health literacy, which is a very important indicator for oral health. Hang on. All right. Yeah. So what we're trying to do is find the high-risk groups. You know, there's 20% of the population's got 80% of the disease, and we want to focus on these. So in the end, we come down to, do we have a high risk or a low risk? And then we talk about, is there an appointment with the oral health educator? And this is recorded in the treatment records, so that it's there for next time, and every examination has to have this in our clinic. Now, when I was doing my homework on this, I came across something which made complete sense. We use recent restorations as an indicator for future dental care or risk of dental care. And that just confirms that restorations have nothing to do with managing dental caries. If we were fixing teeth with restorations, this would not be in there as a risk factor. So that just confirms that. Okay, this is from Featherstone, just adapted from Featherstone in East Canberra. Now, it's a tool for stimulating thinking. It doesn't dictate. So from our experience, after you've done this a few times, it's very quick. And in the end, if you think someone's high risk, they usually are. So it's not that time consuming, but it does create a sort of a critical thinking path. now it gets more interesting, I think, because Vang's going to stand up in a minute. Not yet. But we got moved to the management phase. So as we all know, it's pointless trying to manage caries by treatment. So we have a preventive, educational and treatment phase to this. If you remember before, in the letters we sent out, people have been told that if they don't have good oral hygiene, they're not going to get their treatment. And we call that, in motivational interviewing style, that's the stick of a stick and carrot approach. We'll talk about the carrot in a minute, but the stick is, if you've got high risk, you have to go and see the oral health educator, and whether it's 1, 2 or 3 sessions, depends on the risk and the progress made towards good oral hygiene. But they don't get to move on to any of this treatment phase until they've been through the oral health educator and they've given them the tick off, they're okay to go. Now, of course, common sense dictates that some people are going to need to have some caries control at that point. You don't want, rampant caries going on, so you may be doing some caries control and some initial perio treatment at that phase. So, there may be multiple visits going on there. So we do. Are we going for time? 15. All right, better move it. We have. I've consolidated our treatment planning, a broad general treatment planning like this. We can come back to that if there's any questions. But what we've worked out sort of these codes that would dictate what happens in the treatment plan or the treatment planning and the management. So anyone with a high here gets to see the oral health educator. And that's probably where Vang comes in now. Be nice to her, she's a bit nervous. Well, I've dragged her, God, imagine listening to me for another 20 minutes. So, look, Vang has been with us from the beginning of this, but then she deserted us to go into the hygiene course. So thanks RMIT for stealing Vang, but it's good. And I know that DHSV is looking at career paths for DAs, and I think this model is a really important model for career paths. Of course, you're going to lose people as they become upskilled, but we might be able to use her back into this system later on. So her role is as oral health educator. So I'll just hand over to Vang. She can just explain what she does.
Thank you.
There you go.
Okay, so good morning, I'm Vang. I've been a dental assistant for 7 years. And after obtaining my certificate for an oral health promotion, I'm also known as the oral health assistant. So I'm just going to talk a bit about how I'm involved in the model. So first of all, my primary role is to educate the client and do the prevention part with the client. I'll do the saliva and the plaque test. Just some of the, when they come in to see me for the first appointment, I do a risk assessment. So that's basically a saliva, plaque and a diet kind of test and analysis. And I also do the oral education on oral instructions and just advice on healthy eating and snacking. Help them with the oral hygiene instructions and aids, and also just educating them on the general health and how it impacts your oral health impacts on the general health. Another important factor that I'd like to kind of point out is, of course, help them maintain their oral hygiene, but also it's an important part to actually know your patient, and the building relationships is quite important at this stage. So to get a patient to actually open up and be honest with you, they have to be comfortable with you and trust you. So as Martin mentioned before, that client-centered approach is quite important at this stage. So I find it actually important that I need to determine the individual's attitude and also what their values are to help them succeed in having a good oral hygiene. So, for example, if someone's struggling financially and, no time to think of oral hygiene, I need to address that problem first and find out why. and then help them maintain their oral hygiene. Just to talk a bit about this oral hygiene template that I kind of put together. Yeah, so this is, yeah, I put together, but Ben was the guy who actually helped me put it on the system and make my life a lot more easier to do my notes. And this is just a template to help me monitor and evaluate the client's progress over time to see whether they're actually improving or whether I need to motivate them a bit more. It's just a record that we keep for the client. So I get them back for a review appointment or follow-up appointment. This is where I get to actually assess their motivational level. So for those who, I do get a few fail to attend appointments, and we follow them up to see the reason why they don't come. And for those who actually attend a second appointment, it shows that they are motivated and they are willing to change. So in that appointment, I just assess the gingival condition again and also redo a plaque score. What I find is doing a plaque test is quite effective for the patient, for the client. It's just the reaction I get from them just seeing that colour stain of the plaque and biofilm is quite, it actually scares them, and actually you see that, you know, they're surprised by so it's also just to review the motivation, just to listen to them and assess them and just to discuss any difficulties and just to build up their confidence. And of course, if I see that they're motivated, that they're improving and they're willing to make a change, then I refer them to the dentist for ongoing treatment. Otherwise, if I see that I need to motivate them more or they need to just improve a bit more, then they come back to me for another follow-up appointment. Yeah, so I'll just pass back to Martin.
So look, we're trying to evaluate what we do, and this, what we sort of get two responses from our clients. One is a little bit angry, like the guy in the middle. Why haven't you done this before? I mean, why is it taking you so long to get to the point of helping us to keep our teeth? And the other one is, you know, thank you, you know, thanks. Someone's finally doing something about it and we really appreciate it. So the next phase of our, I should mention actually something about the perio, because we don't want to forget perio. Everyone that has a high-risk perio has to have an OPG, well, they have to have a current OPG and a full perio charting. And quite often, we still live in this dilemma. We have to talk it over with the HSV a bit, or Royal Melbourne Hospital. Do we refer early the cases of high-risk perio, or do we do the initial treatment and then send them on? Because the periodontist is giving us mixed messages, or the periodontists are giving us the message, refer early so we can get down in those floppy pockets, whereas the referral pathway is make sure they're cleaning well and have an initial treatment, and then we'll see them. So that's a little bit confusing for us at the moment. Anyway, the next part, the phase, I call the 3 Rs: recall, review, recall, and referral. So after the oral health educator has done her review here, there may have been some caries control and some preventive stuff beforehand, but then they may go on and do caries management based on risk assessment. That's Featherstone's Canberra. And they may be eligible for complex care, root canal and dentures if they're now looking after doing good oral hygiene. And the dentists like this because actually there's a cleaner mouth, the quality of the actual dental work can be higher. It's all minimal intervention as well. Now if they're, I can probably go to the next slide, because, oh hang on, yes, no, sorry. We have established, we all have child recalls already. We've established an adult recall. Now the adult recall is required as a duty of care. If you're doing minimal intervention, you can't leave someone with a watch, or we'll see you in 3 years and see if that's remineralised, because it's just not ethical. So we've had to, against policy, I suppose, we've started adult recalls. and they may be a recall for the oral health educator, or they may be for the dental operator, depending on the circumstances. If people, and I just, the low risk people just pretty much go straight through. We go through as quickly as possible, scale and clean, the odd filling, bit of a tune up, and they're gone quickly. So most of our time is spent on this high risk group. Now, what about the people who aren't complying? So at the review, there's VANG would go through support, maintenance, and creating a bit of sustainability into their behaviour change. Now this is the carrot. If people, we get their attention by saying, hang on, you're not going to go and have those dentures, you're not going to have that root canal until you're brushing well. It gets their attention. So they have to see VANG, and you know, as Violet wasn't very happy about seeing VANG to start, well, wasn't VANG, it was Jessica, but we turned her from I turned her from a stick to a carrot. We've turned her, we've managed to create the carrot as valuing good oral health and a disease-free mouth. And once you've got to that stage, you're actually starting to get somewhere in changing behaviour and sustainable change. Now, of course, people always relapse because that's just natural for behaviour change. So we've got this, everyone talks about motivational interviewing. Now, I went to a motivational interviewing course, and it took me a full day to really realise what motivational interviewing is. It's a lot different from what tell, show, do and all that sort of stuff. And I believe what is required to get successful motivational interviewing is a high level of trust from your clients. If you can't seem to be their friend on their side, being helpful, there's no way that they're going to change their behaviour because they've heard it all before. Coke's bad for your teeth, you've got to brush your teeth twice. They know all that stuff. There's something else that's going on that's not allowing them to change the behaviour. And this is where motivation, it changes that reluctance of behaviour change. And you have to work really well with the client. It takes a long time and it takes a lot of skill. It's not something that's just, you know, comes off the top of the tongue and there it is. And I believe that what we're doing is setting up our clinic to be able to successfully do motivational interviewing when it's required. We spend a lot of time, and we all do tell, show, do, and with no effect. It's all the stuff beforehand that we don't do that well, which is why this model, I think, can address some of those behaviour changes. So we're creating trust, we're increasing health literacy, and we're creating a form of motivation which can help behaviour change. Now, the other thing is the drop-in clinic. If we've got people who aren't ready or aren't able to change, then they can use the emergency system, or they can come in on a Wednesday afternoon, just drop in and have that tooth fixed as they want. But they won't get their dentures, and they won't get their root canal. I mean, we're not going to leave them in pain, don't get me wrong. But Scott and Dominic are here today, and they would say, I've asked them, and they said, yes, the clients that come through for denture care have got cleaner mouths than other places. And so it seems to be working. Now, oh, sorry, Ron. I think, are we out of time yet? No? Anyway, I'll keep going. I thought I wouldn't have enough to say, so it's going all right. So implications of this. There are implications for the client. Obviously, they're going to have a better experience. There's less pain and discomfort, and they're more empowered to look after their mouths. The community gets a dental home. We think improved health outcomes, we don't know yet. And cost effectiveness, we don't know. I'll talk about that in the next slide. We think that staff satisfaction and retention levels will be improved. There's a lot of skills development training that will continue. And part of the minimal intervention is that if clients have less painful dentistry or invasive dentistry, they're going to be less stressed, which means there's less stress for the dentist. If you've spent a whole day with anxious patients, you're ruined at the end of the day. So we think this will be helpful. And there's obviously organisational benefits. So where to next? This is my last slide, so relief is on the way. We will continue with this model of care with or without support from these other arrows. There's documentation that's nearly completed. We have a sort of a fairly big, well, it's not just rhetorical, but a guiding document. And then we've made a little clinic reference so people can get a bit of the background. Our staff, there's our tools that we're using just for reference and some of the guidelines for risk assessment. We'll continue with that documentation and we'll share that. We'll continue with our policy development. We'll continue to train our DAs in interview techniques, our reception staff in client-centred approaches, and dental operators in minimal intervention. We'll continue to manage our community's expectations so that they actually start demanding preventive care. Now, if we can get to that stage, I think we're really starting to get somewhere. If clients come in and ask the 3 questions. 1, what's my main problem? Why? And what can we do about fixing it? And I don't think there's many clients that come in that ask those questions. Just do what you reckon, Doc. But we want people to come in and demand prevention. That would be great. We will increase our engagement with the needy groups, the visiting schools, aged care facilities, asylum seeker networks, and show up at community days and festivals. What I think at this stage, which would improve our model, would be the introduction of the ICDAS-2 system in terms of diagnosing and managing or treatment planning for caries. I think that would be a useful tool, but I know that's done in research, but if we could get that into titanium somehow, I think that would be beneficial. The funding formula, I've got no idea how the new funding formula will impact on this model. I'll do my best not to let it. I hear fissure sealant's a good value in that system. The word's out. Okay, and research and evaluation. I know Andrea's here. If it's as good as we suspect this model, I think it's an important model, and I think it could. I think it would be very interesting to see how the evaluation came out on it, the cost effectiveness, and we are always happy to take on partners. I know that Bendigo was interested. Oh. Wendy. And there's other people around who've come to me and said, look, we're really interested in this model. So I'm quite happy to share that with you. Thank you.